Hello, everyone. So, first of all, on
Yeah,
the behalf of, yeah, will I continue, sir?
yeah, please go ahead. Everything's
Yeah,
clear.
my
Go ahead.
slides are visible.
Yes, yes, it is.
Okay. First of all, on the behalf of I Love Homeopathy and my group, DARE, I welcome you all in this series of webinar. So, this is very good. I think this is a very good initiative in which we all can connect and share our ideas and learn more things. So, the topic for today, which I have selected, is multidimensional approach in homeopathy and role of repertory in holistic prescription. So, idea for taking this topic is that why there is a need. First of all, this thing came to mind. Why this is the need for today generation. Today we are divided in a lot of things, but we are divided with the systems. We are divided with the way of prescription. We are divided with our way of prescription. Somebody is using repertory, somebody is using Segal method, somebody is using Shankaran method, somebody is using Vijayakar method, and there is a clear distinction between the how the system work or the information we use in cases. So when we stuck into one system, suppose we are using repertory, we will we normally try to solve every case with repertory. So when we are doing a sensation method like by given by Dr. Shankaran, then we will try to solve every case by sensation method, and same with the Sego's method, and same with the Vijayakar method. And then we all know that we get failures. So how to overcome that limitation? As I can tell about my journey when I am using predictive. So in acute cases, I am not able. I'm not using Econite because it is not there in the acute chart, because I am stuck into one system. But soon I realized in why Econite is not in the acute chart, because at their place in Mumbai there is no cases of Econite because no northwest winds. So we have to adapt according to our place and our area and our understanding. So same when I went to another Shankaran system, I stopped using lycopodium because it is not there in chart. So whenever we get ourselves fixed into one box, we get limited. We get limited, and that limitation start expressing in our daily clinical results. So that is why I picked that topic. That is the multi-dimensional approach in homeopathy, that how we can see cases, or how we can take case, or after case we can analyze that case with different dimensions, so that we don't get stuck into these systems or the or our fixed patterns. So we came out of that. So this is the point of today discussion, that how we can overcome that. So so today we will try to understand, we try to bring clarity about when in a case, suppose we are having a case, when we are sure that this is the case for the repertory. So this is the case, or we can, it is better to say ki when in a case we decide that in this particular case we have to start with the repertory, right? Or any other things also, ki when to consider pathology in a case, when not to consider a pathology in a case, when to use thematic system, when not to use thematic system, when to use kingdom classification, when not to use kingdom classification. So we should have a clarity in our mind, ki whenever we start with a case, so what information we are having in the case and what system we are going to use in that case, it should be very clear in our mind. So today, out of these many things, so many things, we will just talk about only one thing, that is how we can, out of so many tools, we can use repertory one of the tool repertory we all use and we all know very well in a more in a open way, so that we don't get carried away by the repertory or rubrics. So we should, so that we have clarity in a case what rubric to take and what rubrics not to consider in a case. As many times we see there are a lot of rubric in a case, but when we repertorize that, we came with nothing. We came with no remedy is clear in that repertorization. So how to overcome that limitation? So this is what we are going to discuss today. So to understand this, what multidimensional, what I mean by multidimensional. So we talk about one case. A few days back, a few weeks back, one case came to me. So she is having a retention of urine, and that is very strange case, because when she's complaining of retention of urine, but she's not having any symptoms with that. No distension, no other problems, no pain. It is approximately 14 days she's not passing the urine. So when doctor said ki she's lying, or maybe she's faking that, or she's feigning her sickness, so she keep her with him for 24 to 48 hours in the hospital on the bed under observation, but she's not passing any urine. So they are not able to understand ki how this is possible. Ki she is not passing a urine, she is having a retention, but she is not having any symptom regarding that. And they also they got RFT done, no change in the RFT. So when she came to me, she's admitted in the hospital and want to do a catheterization, but she want ki maybe homeopathy can help me because she is going on with this problem. When I inquired about that, ki how that all that started, she told me that this started after delivery. And when I got into the story of that, that is more stranger than this. That she told me that she is not able to know that she is pregnant, and when she came to know about that she is pregnant, it is already the 9 months going on, which is very strange for me. For me, it is practically impossible. How it is possible that she is not having any movement and any symptoms? Or then she said, I'm not aware of that, and due to that there is a conflict at their at home in laws, because his mother-in-law saying that you deliberately hidden this from us. But she said ki I am doing my daily routine work day and night, going 3 floors up and down. And presently also, before coming to the hospital, she is washed the clothes and done all the work at home. So how and she said, I'm not feigning, I'm not hiding anything, but I'm not aware of it that I am pregnant. So this is very strange for me. But in this case, I saw one connection. I saw that the, the expression in the pregnancy is also that there is no clarity. Everything is hidden. The symptoms which must come are not coming, right? And same thing is in the uterine issues. In uterine issues also, in sorry, uh, retention of the urine, those symptoms are coming. So here I see the pattern that neither there are symptoms in the pregnancy and nor there are symptoms in the retention of urine. And now I have nothing more than that. Then I inquire about the child. Tell me something about the child. She said ki my child is very quiet. She's not asking for anything. She's happy, she's playful. She didn't cry, she don't ask for a milk, even regular diet. And she is very happy. And the nature of the mother after the delivery, she became very contented, she became very relaxed. She said all in all this uh, issue which is created, which disturbed his whole life, I am totally happy, I'm not disturbed. So in this case, if we open, if we see this case in detail, we can see one pattern running. That one thing is that his body is not expressing the symptoms which her body should express. in case of retention of urine and in case of pregnancy. Along with that, there is a mental state which is going on, which is there in the kid, there in the pregnancy, and thereafter in his mother, that is totally no complaining, contentment, happiness, relaxation. So in this case, I have no other option that I have to take. We all know that we have to take the rubric here, that what is the rubric we should take in this? Painlessness of the painful condition. I consider this as a painlessness of the painful condition. Then I add to that contentment. Then I add to that one more thing, which is her pathology, which is disturbing her. That is retention of urine after delivery. The remedy came out to be, naturally, we all know, that is opium. And it helped her very well. But what is the learning in this case, or what is important thing, which is very important to know in this case? Why this rubric, that painlessness of the painful condition, is important? It is not only in the pathology, it is also in the pregnancy. So this combination of two, the expression of the same expression at two different time places, is very important. Now this is not an individual thing, this became whole, this became this is present at two different time frame, and that is why this become very important. So in this case, this understanding help me a lot. In other case, there is a phobic neurosis and hypertension. So, and in that case, he's having a hypertension along with that palpitation, and there is an issue of suffocation which is going on in, we can say, all the time frame. In the childhood, he is feeling suffocation. During the examination or CT scan, MRI, he is feeling suffocation. When there is hypertension, he is feeling, along with that hypertension, there is suffocation. When he is in a fearful condition, he is feeling suffocation. So along with that suffocation, he is having a lot of fears. You name it and he have it. He have lot of fear of dark, fear of ghost, fear of this, fear of that. Along with that, he was so much fearful that he fear from his landlord. He said when his landlord came in front of me, he feel like that he will eat me. This is very strange, right? And we know that there is a rubric in the repertory. So in this particular case, the fear is there in every aspect, in the childhood, in the young age, along with that, in a acute condition, and along with that, whenever he goes for any investigation or test, that in case of shoulder injury, he went to for an MRI. So along with now, normally in these cases, we get carried away with the idea of that fear and violence in the case, and we tend to prescribe stramonium, belladonna, and many more we can think about in this. So when we say multidimensional, what we mean by multidimensional? Now the thing which is missing here, if we prescribe belladonna or we prescribe stramonium, that is suffocation. So suffocation is not a salient character of the belladonna or stramonium. It is more with the clingy nature. So now what we can do in this case? Now in this case, we can't use repertory as such like in previous case we did. So in this case, we go with the kingdom classification. We will try to understand what is the family which is having fear and violence in the center. And we all know the stramonium family is having the fear and violence in the center. Then I have to read each and every remedy, that what is the remedy which is having this much of fear, and along with that having hypertension, and along with that having specific suffocation, and along with that, is there any particular fear which is having in that remedy also? Then when I read each and every remedy, I came across a remedy which is very similar to belladonna, because it is made from the same belladonna, uh, that is atropine. So when you study atropine, it is having everything, just everything like fear and violence, and it is we all know it is a very good remedy for hypertension. Along with that, is having a very strong symptoms of suffocation, and particularly that atropine is having fear of buried alive, which is there in this patient. So in this case, we use different approach. In the previous case, we use different approach. So if we go with this, so if we understand this, if we see the case, we can say that there are two approaches. One is tailor-made approach, that we get fixed with our idea, we have to use repertory, then every case we have to use the repertory. And second is designer approach, that we take first a case in a full detail, then after a case we decide whether in this case I have to use repertory, or I have to use kingdom classification, or I have to use thematic, or if repertory, then which repertory, right? If repertory, I have to use a Boger-Boning as an approach, or I have to use a Cantanian approach. So we should be very, very clear in our mind. So this is what when I say multi-dimensional approach. And this is not limited in this only. So whenever we study any remedy, suppose we study any remedy, we study Kali, we should know, we should understand through this multi-dimensional approach. For example, I'm having a patient of a Kali, but his pathology. Hello.
Yeah.
Yeah, there
I think it
is
is some
some
glitch.
voice. Yeah, yeah,
Yeah.
yeah. Suppose we are at Kali. So
Yeah.
suppose I'm having a patient which seemed to me as a, from my experience, he seems like Kali Kab. We repertorize the Kali Kab is coming, but his the pathogenesis of the patient is of the sinuses, right? He's having the issue of the sinus. Then we know that Kali Kab is not as known for the sinuses. Kali Bai is known for the sinuses. Same, if patient is having more anxious than what we read in Kalika, he is having a much more anxiety, especially in the heart area, or in regarding the heart disease, or anxiety about the health, which is much more than Kalika. Then we go for the Kali Ars. Suppose patient is having the repertorization Kalikab is coming, and the patient which we are seeing is having more chronicity, glands are involved, or there is a more chronicity, or pathology is very severe. So we can say that we can, it is better to go with the Kali iode rather than the Kali Kab. So this slight change, or this slight, we can say, fine tuning, it is very, very crucial and very, very important. And this can be a game changer in any prescription which you prescribe in the daily routine. So this is what when I say multidimensional. Multidimensional means we take all dimension together and try to understand the case. My teacher always said that the bit that does not fit is the key to the case. So we, and our tendency, normal tendency is to ignore that bit. Like in this case of atropine, that fear, the dreams of buried alive, it is there in the prover, and it is there in the patient also. But if we are fixed with the stramonium or belladonna, then we say, oh, it is fear, so no problem, the fear is there in stramonium. But that fine tuning is very important, and that is why we need that approach, the multi-dimensional approach. So this is very important for us. And as we all know that we can say that the carpenter, we are just like a carpenter having a different tools together. Because if we are having only one tool, you know what we can do in that condition, we try to solve each problem. Then each problem, if we are having a hammer, then each problem look like a nail. So whenever having a one system or one method, which we are, or we are in tune to, then we see case in that dimensional only, that dimension, one dimensional only. And that is the reason we need a multi-dimensional approach. Then second thing of today's discussion, when now we are having a case, when in a case we are sure and we know that out of so many tools we are having, here in this particular case, repertory is first which we have to use. And this is very, very important understanding, because we can't start all cases with the repertory, but we should know very, very clearly what are the cases in which the first we have to use the repertory. So today we will discuss this, what are the things or what are the cases in which we have to start with the repertory. So before that, we must know our repertory very well, and we must know the limitations of our repertory very well, right? For example, Doctor Along, with your gaps and using use of gaps, there is some problem. So to remove the gaps and use the multidimensional system.
Yeah.
Hello,
Yeah.
hello.
Now it's clear. I think there's some loose connection there.
Okay, okay, sir.
Hmm.
So how we have to know the limitation of our repertory? So suppose I am having a case. Now, repertory as a tool and repertory as a limitation. We must know that, right? This is very important. So that is why I normally, when I talk with my friends, or I said that I always talk like this: ki repertory is our friend, but it is a headless friend. Repertory is not having head of its own. We should have our head, and we should use our head and use repertory in a way it should be used. So, like there is a one case, a very small example of the case. His issue is very simple. He came to me with the simple problem, that is sleep over problem. But it is not a simple sleep over problem. He sleep even while driving a two wheeler. He sleep while doing his regular work in a factory. So much. In this patient, his patient is having a very sudden sleep. Sudden. Within a few minutes, he can sleep in a deep sleep, and is not aware of that. So now he came for this problem only. He is not having another issues in his life. So now what to do? So here the role of a repertory is very important. So now now we should, it is not like mathematical ki just we take rubric sleep overpowering, and along with that we add few more rubrics which we can get out of that patient. That we all are having many symptoms. We all are little bit timid. We all are a little bit shy. We all are having jealousy. We all are having thirst and thermals. We can add to this rubric and came out with the polycrust or some remedy which is having sleep overpowering. But here in this case, or in any given case, we have to match that exactly. The intensity of that sleep in that patient, it is too much. It is characteristic, it is peculiar that he's sleep while driving a two-wheeler. We can sleep in a four-wheeler, but in a two-wheeler, while doing his factory work, he slept while doing his regular factory work, and that also in the few minutes. Then this repertory can be an important tool in this case. How? But how I approach in this guy, I took one journal rubric sleep over problem and read each remedy one by one. There is no other way. We have to do like this. When we read each and every remedy, then I came across one remedy in which proving it was written that a prover, when he drink the mother tincture of that remedy, he completely is taken off. He felt in a deep sleep, and when he woke up, there is a noon, that noon time, and the bottle in one hand and cork in other hand, and is not able to know what happened to me. So that is the intensity of the sleep that remedy is having. So remedy is this one. So it was written, the sleep, the most profound that ever experienced, arrested me so abruptly that I remained motionless for the whole night, uncorked while in one hand, and sun was high above the horizon. So the intensity of the sleep covering. in the patient should match with the intensity in the patient. So we can't give just opium or nux muscat or any other remedy which is having sleep overpowering. But we can do that when we add just other rubrics, right? So we must very, very clear when we add rubric, because one wrong rubric in medicine is out of the chart or total out of the consideration. So in in our understanding, we not only go for the similarity, we should go for the exactness with that. But we also know the limitation of the tool. The limitation is very clear. Suppose when we see when we read in Cantharis, this one of the patient of mine, he told me that there is he can listen voices, he can hear voices, right? That he can hear footsteps, that somebody is coming. Then he felt that somebody is under the table, right, and under his bed, and he is about to grasp him, and his hands are cold. Now this is the proving symptom of Cantharis, that the vision at the night half awake, he heard footsteps knocking under the bed. Bed was raised. Something took hold of her hand, and that hands are icy cold. But when this expression goes to the repertory, it just lost its whole essence. It divides and it gets scattered in whole repertory. It becomes delusion hear footstep, delusion of hearing, delusion hear voices, delusion bed raised, delusion somebody under the bed, delusion he will be choked. So if we see that the whole essence of Cantharis patient is just gone. So here we are with it's with bit pieces of the information, and that is why it is very important that we must know our tool, that our tool is just an index. So we have to go back to the material medical to understand this. Like these are two rubrics that branches vigorously CPM, sleep physician, sleep cleanses, any remedy sulfur. But and many times this happen, we bring with new understanding and new explanation of the rubrics, right? We say we talk about the metaphors, right? But we have to see that from where it is coming, and when we refer to the repertory, these rubrics are added by the veterinary doctor, and they are the symptoms in animals and not in the humans. So we must know our tool very well. First, when to use repertory and when not to use repertory, and when we are using repertory, which rubric to take and which rubric we not to have we not have to consider that rubric, and then which repertory to use, which repertory not to use, and then how to use that repertory. So we should have that clarity in our mind. So that is the second part which we are going to discuss, and this is very important, right? So what is the second part? So now coming to that, key, when we have to use a tool repertory first in a case. Now what are that type of cases which call for the repertory? They themselves cases talk about that key. Let's use repertory first. Now we normally we see two types of patient in our clinic. Suppose example I have given here, that patient talks about bonding, patient talks about love, patient talks about togetherness. Now there are two type of expression. In one, patient talks in full detail about the love, bond, and togetherness. He express in whole totality. The bonding for me is like being one unit. It's not simple. That's one of the patient told me, that this is not my bonding. My bonding is like this. It should be very, very strong. It should like a covalent bond and not a simple bond. So that those patients which express that that symptom in whole detail, we need a different approach. But when we get stuck in a case with just one symptom, like bonding, and there is no explanation to that bonding, or any mental symptom like dreams of snake, no explanation after that dream of snake, or suffocation or excitement, but there is no explanation with excitement, no we can say no experience attached to that excitement, no experience attached to that constriction. They are the cases which need repertory first. So that is very important. Those are the cases in which we have symptom at the mental, physical, or journal level, which are not having experience attached to them, and that in that cases we need repertory first. Then when we are clear that now in this case we need repertory, then when we repertorize we are having so many symptoms, then we must be very clear whether we are taking everything together, right? And we all know that when we take everything together, we came up with some polycrust, no problem, no issues with that, and we can confirm that remedy also. We are master in that, right? So patient is front of us, and if we are decided that we are going to give lycopodium to him, then we can confirm it for sure. We all doing it since long. But how we can overcome this limitation of our mind also, that is biasness, right? How to overcome that, and how to understand that out of that bunch of information, what information is that which is we going to use in this case, and that clarity is very important. For that clarity, I'm going to give you example which is given by my master, Dr. Dinesh. He explained me this understanding beautifully. He told me, suppose in a case, right, we have excitement. Excitement as a whole level. When I say at the whole level means, like in the first case, there is no symptom, and that no symptoms, it is at the whole level means that is in the pregnancy also, in the patient also, the contentment in the child also, and in the patient also. So that contentment and that painlessness of the painful condition which we apply is present at the whole level. It is not at present at the isolated area in that area. For suppose in the pathology only, it is not in the pathology only, it is also in the pregnancy only, it is also there in the pregnancy. So here, for example, excitement is at the whole level, means in the mind, in the dream, in the hobby, excitement is everywhere. And patient is telling that I am very upset with the listening to the stories of suppose injury or accident, but I feel excited after that listening to all this stuff. And patient has having a very strong desire for wine, very strong, it is plus, has a strong desire for a coffee, has a strong desire for a sour things, has a strong desire for the spicy and stimulants, right? And patient said he feel excited after eating all this. And then he tell कि whenever he feel excited, his whole body trembles. He want to talk. He become loquacious after excitement. And whenever he is overexcited, the best thing to relax himself is that sitting in the knee elbow position that make him feel better. And when we seen that case in the childhood, there is a strong fear of ghost and there is a desire for ice cream, very strong. Now in this case, we are having excitement, we are having a sad stories affect us profoundly, we are having a wine desire, we have having a coffee desire, we having a sour thing desire, we having a spices and stimulant desire, we having a trembling with the excitement, we having a loquacity in this, we are having a fear of ghost, and we have an ice cream desire. Now in this case, we are not having experience of the excitement, so we are sure कि now in this case we have to use repertory as a tool. Now out of so many things what to take and what not to take, so mostly what we do in regular basis, we took all the rubric, we took excitement, we took desire wine and all the desire, because all the desires are very strong, we took loquacious, we took the trembling with excitement, we took fear of ghost, we took ice cream. But here is the catch, because if we do this again, we are going to came up with the same polycrust remedies, because we just put everything inside, there is no mind to it, right? We here we just apply repertory mathematically. Now, what we can do in this? Now, try to understand. It takes just 1 minute. If you see what patient is telling, that when he drink wine, it excites him. When he drink coffee, it excites him. When he desires sour, it excites him. When he drink coffee, it excites him. And whenever he takes stimulants, it excites them. And even listening to that stories also excite him. So all these things which desire which we are getting are just another expression of his whole, that is excitement. So everything is coming from excitement. Everything is connected with excitement. So if we took all rubrics together, we are taking only one information in the case, that is excitement. And that is why we failed in these type of cases. So in these rubric, everything is coming from excitement, or we can say everything is making him excite. So in this particular case, we should not first considered all these desires and aversion, in spite of all of them having a very strong information. So first, in this case, if I am using this, then I will take first excitement. Then is see what else is the information which is important along with that excitement. So second thing which is important is trembling and loquacity. So it is not because of excitement, but it is as a complement. It is not exciting. Loquacity is not exciting him, or trembling is not exciting him. It is coming associating with that excitement, which we normally know as concomitant. So here I will take first excitement, then I will take loquacity, third I will take trembling with excitement, and then what about that fear of ghost and desire ice cream, which is plus plus in his childhood? We should not consider that, because in childhood this is the common desire we get, ice cream and chocolates. Along with that, the fear of ghost, it is very common in children. So here, rather than taking all the rubrics together, right, we should go for an clear idea that what we will take. So in this, we will go for excitement, we go for loquacity, we go for excitement with the trembling and the amelioration part of the excitement. So in that case, it is a good chance that we will come to a remedy which is having, which we need in that particular case. I give you one more example, right? Suppose patient is having a suffocation. Patient came to you and he is telling that I'm having suffocation and constriction, and it is there in all level, right? Constriction and suffocation, it is there in all level. It is not a part of a case that we see in previous atropine case. It is a part of a case, suffocation. Whenever he fear, he feels suffocated, right? But in this case, we have suffocation and constriction, but we are not having experience of that suffocation and constriction. So this qualify that this is the case, we should start with the repertory. Then we get symptom ki whenever he feels suffocated, he having perspiration on the upper lip. Whenever he feels suffocated, right, he is having a dreams of the snake. Whenever he feels suffocated, he crave for the sweet. And there is a modality that he feel better overall in the journal by walking, and he is timid in nature. So in this case, again we can do same mistake, we combine everything together. But now we have to understand how we can go in this case in a way that we can easily get to the remedy, which what remedy we have to prescribe in that case. So in this case, what I should do, what we should do, that we should not consider, we should first consider ki what are the things which are attached to the center issue of the patient, that is suffocation and constriction, that at perspiration upper lip, that is having dreams of snake, that is craving for the sweet. So I have to took three information in this case, that is upper lip, perspiration upper lip, then dreams of the snake, then I will take the sweet desire. And when I take these three rubrics, then I have to look in that list of the rubrics, remedies which are covering, which is having suffocation and constriction in the center, in which this feeling of suffocation and constriction in very strong part in that remedy, right? So here, if we do this, the chances of the failure, or we can say the chances of getting wrong, are very, very, very less, right? So when we come to one more case, and we will end up this session. This kid came to me for this problem, the alopecia totalis, and in his whole condition, what is the information we are having? Otherwise, a very calm and very shy kid, right? Never disturb his parents during the childhood. But what happened in the school? One of the teacher in front, something happened in the school, some issue. His name came in that, and he is not involved in that issue in the school. But his teacher talked about him in front of the school and scolded him, and he feel very angry and humiliated in that condition. He feel embarrassed, right? Because everybody is laughing in that assembly, and everybody start teasing him due to that situation. And that is the time when his hair fall started. And when hair fall started, it not responding to any medicine and not getting wet with any treatment. So when he came to me, he lost everything, and no hair on the body, whole body. And when I inquired what happened after that, he said after this thing, his PT teacher, he just removed the cap. And that time he is having an alopecia, that spots, the bald spots on the head. Remove his cap in front of everybody. Then again he feel humiliated. He feel very bad and he feel angry in that, and very embarrassing. Stop going to school at all. And after that, this thing happened. He start losing his hair in whole head, and it became the case of alopecia totalis. So along with that, he other information in case which are very important. Ki whenever this situation happens, he weeps a lot. He weeps very easily. He weeps with small things. Along with that, whenever he weeps, there is a vomiting along with that. These are the another information along with that other information in this case. So in this case also, I'm having one information, that is embarrassment, and along with that, that anger feeling in that patient, and I am having no experience to that, experience of that embarrassment. Like one of the patient, he told me, for me embarrassment is like, ki, you take me to the street and strip all my clothes, and everybody is laughing on me. This is embarrassment for me. For example, I am in an army, and my junior is torn my clothes, and I am court martial, and everybody is laughing at me, and everybody in the around me will talk about that he has done so much bad to his name. So this is the whole embarrassment. So that patient explained whole view about his embarrassment. But in this particular case, I'm having simple information about embarrassment, so no other information rather than that. Now this is the area where we have to use repertory. So in this, we know that there are rubric embarrassment, elements of embarrassment. Now, along with that, there is a strong anger in him. There is strong anger. He want to react, but he did not react in that case. So I took one more rubric and combined, that is ailment from mortification. Mortification, humiliation, chagrin. Why? Because it is a larger rubric. Because embarrassment is a smaller rubric, so that I don't miss any remedy. So I combine these two, because mortification means it is ailments from mortification, humiliation, chagrin, right? And mortification in Hindi means atma daman, indriya daman. So repression of our inner forces, that is kam, krodh, lobh, moh, ahankar, all the five. And that is the reason the conium is there in mortification, because in conium there is a sexual repression, in not anger, only anger. So in mortification there are five parts, that is kam, krodh, lobh, moh, ahankar. So I took a bigger rubric so that I don't miss that in the case. So with this, I attach one more which is associated with that embarrassment, that is weeping. Now the remedies which are coming, now I have to see the other part of the case which is present in that case, that is vomiting with weeping. And now when I attach that, I came with pulsatilla. And when I read pulsatilla, I also got one more rubric. that is vomiting after mortification, or I think she was weeping after mortification. So I prescribed pulsatilla in this case. This and pulsatilla bring this change in him overall. And unluckily, he met with an accident. He went into a coma, and he stayed. He was in a coma for many months. Then again they contact to me that then I prescribe hypericum in that case on that present totality. Now he's out of that coma and now able to recognize everybody and getting back to his normal life after that. So what we discussed today is very important. First, we should have a clarity in our mind according to the tools we are having. We should not get fixed to one tool. We should all the tools, right? It is like, so it like a person having a many weapons in the armor, right? You cannot, for example, you cannot kill a simple a crow with the tank, right? You need one air gun. One air gun is enough. You must know your tools very well. So out of that tools, you must know when to use what tool in that particular case. Because when you know that, that clarity will bring freedom, and it will also give it also help you get better result. So today we discussed that we should not be fixed in a box. We should be free to use all the possible tools we have. And today we discuss only one tool, that is repertory. We talk about its utility and its limitation. After that, we talk about in a given case how to use that. That in a given case, if you are having one symptom which is at the whole level, and that other symptoms are just getting covered in that only, we should not consider that, like in excitement and desire for coffee and desire for wine and desire everything is giving going back to that excitement. So we should not use for repetization, because it is just expression of that. So by understanding this, we can use our repertory better in many ways. So this is what I want to share in today session. So once again, on behalf of the DARE, and I want to special thanks to the Dr. Karthik Raghavamurthy for giving us a beautiful and wonderful space and audience. And thank you, sir, for this opportunity and space, sir. For this, bye everybody. Any questions? Sorry, any questions are welcome. I'm not able to listen. Sir. Hello. Hello.
Yeah, hello.
Now I'm able to listen to you,
Yeah,
sir.
now
I'm
you're
not
able
able
to
to
hear.
listen. Yes, sir.
Doctor, can you check the messages? There's a Dr. Akanksha who wants to know
Yes, sir. Yeah,
whether,
I think.
yeah, you can just check that.
Yeah. In her previous history also, he's having this symptom, that he's having a very we can say that very less symptoms in the pregnancy, but not like this, that he's not aware of pregnancy at all. That she went to hospital for a distension of her abdomen. When doctor checked, she said, okay, this is a pregnancy of 6 months. But when they get scan done, it came out to be a 9 months, and he delivered a healthy baby after 20 days of that situation. I think in 11 or 12 days after that. So this is very strange. Basically, it is, so we can say that is it is very strong information in that case. Along with that, its pathology also, it is just same. For 14 days, she is not having any symptom. And she went to every nephrologist says that there is no issues with the kidney. Neurologist say that there is no problem with the bladder nervous issues or any muscular issue. So then they went to psychiatrist, and they said no, she may be feigning, and they keep her for 48 hours. Then also there is no passing of urine, and in spite of no passing of the urine, she is not having any symptom at all, and her body is not expressing at all. So that is why it is become holistic for me. Okay, that information is there in this also, and this also, it is going on. Am I making sense?
Dr. Akanksha, yeah, okay. Does anybody else have anything else to ask Dr. Yogesh? You can either type it out or you can request permission for broadcast, and you can ask the doctor directly. So I don't think there's anybody who's there to
Yeah.
ask any questions, Doctor. So I'd like to thank you, Doctor, and also thank Dare, Dr. Pramila, for suggesting you again, once again, and really enjoyed this. We learned a lot, and I hope all the other participants also learned a lot from this.
Thank you, sir. Thanks a
Yeah.
lot, sir.
Thank you so much.
Thank you, sir. Bye, everybody.
Yeah. Everybody, bye.